next speaker needs no introduction. Dr. Nima is going to talk to us about TNK versus tPA for acute ischemic stroke.
All right. Hello again. Thank you for staying here this afternoon. Great conference, exciting talks. I'm going to talk about tPA and TNK in 15 minutes. That's the time I have. And we have a break. And after that, we have a very exciting talk on pediatric stroke. So stay there. And then we have cocktail hour. So I was selected to give this talk, although I am very interested in this topic. I don't have any disclosure, but I do have to thank Dr. Caitlin D'Souza because she helped me with some of these slides, or I stole her or took her slides with her permission. So as you know, stroke happens because you have a clot that goes up to the brain. So that's the embolic stroke. Or you have atherosclerotic disease from artery to artery. But it's all about this thrombus and clot. And the thrombus clot forms because we have the clotting cascade, which cross-link the fibrin. And then we have the platelet-rich platelet that aggravates and causes clot. So these are the two pathways that we have that cause this problem. So depending on the etiology, obviously we try to prevent it from forming by using antiplatelet or anticoagulant. But if it does form, then what do we do? Well, there is the way the tPA works is it activates plasminogen to plasmin, and plasmin cuts off fibrin and degrades fibrin, so then dissolves the clot. So the good thing about this is if you don't have clot, if you give tPA to normal people, it shouldn't really cause any problem, right? So it works by activating plasmin to degrade, to get rid of fibrin. So that's the thing about tPA. Now, the dose, you give it 0.9 mg per kg, you give 10% as a bolus, and then you give the remaining over 1 hour. And I'm going to talk about this a little more, but think about it. So we have nurses here, we have APPs. I mean, dealing with the drip and hanging stuff, I mean, that's time consuming. And then you have to take the patient to different places. So for 1 hour, you have to infuse this product. Obviously, there's a cost associated with it, but we do have prominent trials showing there's a benefit. So IV tPA within 3 hours is standard of care, FDA approved, up to 4.5 hours is what we give it. And INDS was the trial that basically started showing benefit of tPA, and tPA became FDA approved in 1996. This was an interesting new trial that showed, yes, IV tPA, especially within the first 3 hours, has a very, very good fragility index. And I like to think of Dr. Naval whenever I talk about fragility index because he gets very excited about this. But the bottom line of this slide is, nowadays with the trials, we know that the tPA trials are very effective. All right. By the way, tPA is time dependent. So sooner you give it, better it works. So number needed to treat, you can see that improves sooner you give it, especially within the first 90 minutes. So how about TNK? What is TNK? Well, TNK is Tenecteplase. It's a recombinant tPA. So basically 3 sites of the tPA was changed and it became tPA. It's used in STEMI. So actually it is standard in STEMI. There are trials and it is available. So why the appeal? Why do people start talking about TNK versus tPA? Well, it's supposed to have increased fibrin specificity and maybe longer acting, and can be given as a 5-minute bolus. That for me is the attractive part of TNK. Like we talked about, giving a bolus, hanging it over an hour, tPA can be problematic, right? Where you can just push a drug within 5 minutes and then you're done. You don't have to worry about dealing with the drip. So that's the appeal. But what is the evidence? Well, by the way, going back to the appeal, I talked about the time, half-life, but there are also a cost. So TNK may be cheaper. So what's the evidence in stroke? Well, that's where it gets messy. I was looking at these trials, to be honest, my head starts spinning. I there are many trials, no solid phase 3 randomized trial head to head. So what do we have? Our summary of many trials. So in 2010, basically, we tried to figure out the dose of the TNK. We found out that 0.4 milligram maybe increased risk of hemorrhage. So let's not use that dose. Then in 2012, Australia found that actually tPA maybe opens up the blood vessel a little bit better than tPA. Then we have other trials in 2015, 2017, which did randomize, but the smaller numbers, they stopped early, and none of them show superiority of one versus the other. Extend IA was an interesting trial because it's a trial that actually looked at TNK in large vessel occlusion. And it did find that when you give 0.25 milligram per kg of TNK versus tPA, actually more patients with LVO have recanalization, meaning that TNK may be better at opening up the large vessel occlusion compared to tPA. And basically these are the results of Extend IA. And the meta-analysis of TNK versus tPA in 2019 again showed no inferiority. So I think at this point we know that even though we don't have level 1 evidence, but I think we have not proven one is better than the other. And this pooled baseline analysis showed the dose, perhaps a 0.25 is a dose that we need to use. And again, non-inferiority is what we've seen. There was a recent trial in 2022 in Canada, which looked at tPA versus TNK within 4.5 hours. It was a randomized trial. And the rate of good outcome, again, surprisingly, in TNK was 36.9, in tPA was 34.8, meaning not significantly different. And rate of hemorrhage, pretty same. So bottom line, I keep showing you the evidence, or at least I kept looking at the trials, and I'll see that, okay, doesn't look to be much different between the two. So interpretation of this trial was, it is a reasonable alternative to tPA, all patients who present with acute ischemic stroke who meet the criteria. And there are obviously ongoing trials, so we're going to learn about them. One of these trials, Timeless, is the one that actually we are involved, and I hope that we can at least enroll one more patient. Basically, we're giving TNK within 24 hours based on imaging in a large vessel occlusion. So here is the question, and I hope that I can maybe start a debate. So at least within our Baptist system, there is a chance that we could switch to TNK. Maybe we will, if we can all get convinced or not. So what do we do now? So I showed you some evidence. There's no non-inferiority. So do we continue the current method, what we do with tPA? Do we consider changing TNK to certain population, maybe just the LVOs, maybe some non-LVOs? Do we combine them? It does make sense for transfer patients. One, obviously, there are a few challenges. Some of the trials that we're involved with, because TNK is not FDA approved, we're not able to use TNK. So if you give TNK, then we cannot enroll those patients in the trial. Obviously, there are other challenges, right? So you have to change the whole process, the ER. I think we have some people from the emergency room, from pharmacy, from different centers, but we do have TNK available. And that's one thing that we could do. So that's all I have prepared, because I was hoping we can open up some discussion, and maybe some of you guys can help change at least my mind, because I'm not 100% convinced, to be honest. I know what I prefer personally, but maybe you guys can help change maybe Dr. Hanel's opinion on this matter, or I know Wendy has a strong feeling about certain things, TNK being one of them. I know our pharmacy has some preference, but to be honest, we don't have evidence, so I cannot stand here and tell you one is better than the other, but it does have some appeal. So with that, I thank you for your time, and let's have a conversation. Thank you.
Don't hide your feelings, man. What is your preference?
I think I've expressed my preference. I mean, look, if you give a drug, let me go back. Whoever have given tPA have dealt with problems, right? There was a most ridiculous problem that I had faced, which was Joint Commission gave us a hard time because when you give the drug, the end part of the drug sometimes doesn't get flushed because I don't know the details. I guess you have to manually flush it or whatever. So there's some tPA left in the tube. Now, trust me, this is not something that I would have ever thought of. I'm like, what does that even mean? So bottom line, there's problem goes with tPA. Now, let me tell you another problem. So another problem is you give the bolus and then you hang the continuous, right? What if the continuous doesn't get hanged? It has happened. And then you transfer the patient, right? So now you have to transfer the patient with the line for 1 hour. The nursing, there's a lot of work goes into that. You have to take the patient to MRI. You have that going on. So there are issues going on in this 1 hour infusion, which I have a problem with. So if you tell me 5 minutes, give this drug and done, man, I think I will go with that.
Good. Oh, no, I was just gonna agree with you, Dr. Nima. When we get patients.
Thank you, by the way.
Well, when we get patients to the OR, we're getting them transferred to us. And when it's a quick thrombectomy, then they're going to be transferred to the ICU. That could all happen within the 1 hour tPA timeline. And that's a lot of different hands on that patient. And you're relying on this process of tPA to continue seamlessly through all of that. Whereas it sounds like TNK, it could be all done with just one nurse or one provider giving the drug, and then you're done. It just seems like a safer option.
I'm a big fan of if you do what you've always done, you're going to get what you've always got. And so from the evidence we've seen, or at least we heard in the nursing session as well, there's a little bit more evidence to see that this is slightly safer, and the administration, at least the peak times and all those things take a little bit longer. So it seems a little bit safer as well. And definitely trying to get a patient on the table when you're handling drips and all of those things, could be a little bit easier. So.
Yeah, so I'm a stroke fellow here at UF Jacksonville, and we use TNK. And I think from Baptist experience, I know that you guys catch a lot of patients that are being transferred to downtown for procedures. So instead of doing the drip and chip, that requires special staff to be able to manage drips and be able to transport these patients, you can just give it go. So I'm with the pro TNK, I guess you could say, where one, it's more cost effective for the patient. It has higher specificity to fibrin. So you would hope that it's more specific to the specific clot. And I believe, if I'm not quoting incorrectly, that there was a less or smaller chance of having outside of, or I can't say the word, of generalized bleeding because of the higher specificity. So I think it's better, especially if you're on the receiving end of several outside hospitals, that the give and go is probably the way to go.
Thank you. There's a question on that.
Thank you. My preference for transfers from, especially with an LVO, to use TNK, but there's one big dilemma that I don't think we can look at it lightly. Is one drug is FDA approved, one drug is not, and when there's a complication, the patient's gonna ask you, why do you go from an FDA approved drug to a non-FDA approved drug? When I approach our colleagues in Brunswick and Camden, that's their biggest concern. And that's why what Sandwich mentioned also in Cornell, they're waiting because it's not FDA approved. So that's something that's hard to digest. And I'm not sure also from a reimbursement standpoint. I know it's cheaper, but would the insurance companies pay for it as well, since it's not FDA approved? I don't know that question.
Yeah, that's a tough one. The FDA is one of the problems, but we can make a system-based decision, and that will become not an individual decision, right? So if you can, as a center, we can say, system, we have decided that, so it wouldn't be individual physician because you're not really choosing.
Dr. Nima, just from the ER standpoint, I think, especially when we are transferring patients from the freestandings and the nursing staff, this is no brainer that J&J is better. for us. But Dr. Chamsani mentioned something about the FDA approval. I think that we all agree from the nursing standpoint, and for us, even during the calculation, you have to calculate and you have to dispose remaining of the tPA. So I think that once it gets approved, based on the studies that you mentioned, I think consensus that, we just go with the TNK.
Yeah. Unfortunately, I don't think these studies are going to let. I don't think the component. I don't know if there's somebody from Genentech in the room, but I don't think there's not even an idea from Genentech to submit this to the FDA. Again, if you think about 3 to 4.5 is not FDA approved, and we do this off-label use based on American Heart. So maybe what's going to happen, Mohammed, is TNK will become class 1 evidence from American Heart, and we're going to use TNK just like we do tPA from 3 to 4.5, because that's not FDA approved. And what applies to TNK clinical trials of thrombectomy, most of them also applies for tPA from 3 to 4.5. So if the patient gets an IV tPA 3.5 hours post symptoms onset, this patient is off-label use of a medication. So I think American Heart and Stroke Association may settle that for us, because if it becomes class 1 evidence on their side, that's just like giving tPA from 3 to 4.5 is the same type of off-label use with implications related to that. But I think it'll be more palatable. I don't think the FDA, that I'm aware, Raul Nogueira and I with Siddiqui brought this up to the company, to Genentech. I said, look, this is a problem for us. Why, you guys? And there was a bunch of no direct, no intention from the company to take this to the FDA. That would help us to go in that direction. I struggle because 40% of our patients that we enroll in clinical trials from neuroprotection, and now not candidates anymore, but before, but new ones coming. If you use an off-label use of a medication, that patient cannot be part of a study. So we will deprive patients from the potential to get what is coming next. But again, I see the momentum in the room, and I think Pittsburgh, we talked to Tudor, they are TNK, Demetrius, they are TNK, and I think when Wendy's ready, I think we're just going to pick a date, and naturally we'll have to discuss that internally. But I think Wendy wants to give a long time to think. She's thinking about September 15. I'm kidding.
Right behind you.
So when it comes to off-label and medical legal, we have a lot of, we're allowed to use a lot of medications off-label, like Neurontin is used for everything, but it's only used for diabetic neuropathy, but they use it for tooth pain. So I don't think you have to worry about medical legal for off-label. If you do get in trouble with something legal, you're going to be judged if you deviate from standard of care. And so if you're using the thrombolytic within the standard of care, your peers shouldn't hang you.
American Heart does have a recommendation, I believe, that does says that, it is reasonable alternative. So we do have guidelines, even though it's not FDA. So.
Jason, just a word of caution, is way more complicated than that, because if you are off-label, it's not your peers, is the lawyer and what is going to be created just because you made a decision that is not 100% on the book. And by all means, off-label is our middle name. Plavix is not approved for anything that we do. We do because, okay, this study showed that, and there's some evidence of that. So off-label in neuroscience, that's if you don't like to do off-label, you're on the wrong side of the moon. But again, it can bring, and I'm aware of other situations that the off-label use of a device specifically create all kinds of questioning. Why, doctor, you chose to use that if you have other alternatives that are on label? So that if the patient doesn't bleed, great. If he bleeds, it may be open to a question that may not go anywhere.
But I mean, really, as a system, if you change your protocol, I don't see today's with TNK, I don't see how that would stand. But with that, any other questions, comments? Anybody likes tPA? Nobody has said they really love tPA. No? Okay. Okay. All right. All right, guys. Thank you very much.